34 years old who complains of palpitations. He comes for a review, and this is the ECG. So what is the finding and what can be the likely cause of these palpitations? I think it's more of a spot diagnosis. You just have to pick that. Okay. The thing is, it's pretty obvious, but your eye should be trained to just skim through all the facts, all the parameters. So what's the diagnosis?
It looks like early reproductive syndromes.
Okay, anything else? Just
QT
don't.
prolongation is there.
Yes, yes. Don't miss this diagnosis, please. This is exam favorite. Okay,
Yeah.
this is exam favorite. They will not give you a very long QT. Obviously, at your level, they will give you a bit of intermediate prolonged QT. Don't expect to be a very long QT, although this is a prolonged, if you can pick it. But this is nothing else. Is why this patient is having palpitations. Think why early repolarization will give palpitations. There's no pathway, and there's no atrial topics, and he's a young man. So think of channelopathies, Brugada, ARVC, and channelopathies. Rule out channelopathies. Short QT can also come. It has appeared in the exam. So short QT, a long QT, and all these things. Okay, so here, okay, I measure that interval. I'll show you the next slide because I think it's so this is a zoom in view. So this is from here to here. It's around crossing the midline, you see. So anything that crosses the midline, always think of long QT, measure the QT interval. Otherwise, you have to properly measure the QT interval. So the QT interval in this case was 493. You see? So this is definitely prolonged. So what is the cutoff for a QT prolongation who is a patient at highest risk for sudden cardiac arrest? What is the cutoff value for that? 500. Okay, 500, 500. So please remember that value because they might ask you. If they ask you QT, then high risk features just like pathway, they might ask you. So QT prolongation, you should be knowing, important for the exam. Do go and read the guidelines. Okay, so I'll give you now a brief outview for QT prolongation. Just you can remember these points. So for a QT, you have to measure from the start of QRS to the end of T wave. The leads preferred are lead 2, lead V5, and lead V6. These are the leads where the end of T wave is very clearly seen. Okay, otherwise, see any CG where the T wave is ending pretty discrete. Otherwise, these leads is a leads more commonly in which you can see that. So don't mix the end of T wave with because definitely even a one small box can change the QT interval to 40 milliseconds. So huge difference. So measure the average of 3 to 5 cycles along the same routine standards. When that end of T wave is indistant because you can sometimes see a Q wave, U wave can physiologically be seen as well. So what will you do in that case? Look for lead AVR and AVL. These are leads in which U waves are not commonly seen. So go and look for leads AVR and AVL. And these are the normal cutoffs. So in this patient, it was 493. So the prolong is more than 470. So it was a prolong. And above 500 is a high risk. You see, very narrow margin. So the intervals are important. Okay, so these are just kind of a pulse in the case of QT measurement. And so now anyone who can tell me which is QT1, long QT1, long QT2, and long QT3. So anyone who can, I've given you 3 ECGs. You can tell me which is long QT1, long QT2, and long QT3. Okay, so at least you should be knowing these long QTs. These 3 long QTs are very important. So first one is long QT1, second is long QT2, QT3 is 3. Okay, so it's systematically written. Okay, so long QT1 is smooth, broad T wave, and the T wave has, so it's a smooth uptake and a smooth downslope, and but there is no sharp defined uptake. It's a very smooth, but it's a very not distant. So it takes a bit of slope and then goes down. So broad-based, it is broad-based, it is smooth, it is not distant, and high amplitude. It's difficult to pick, but you should be knowing these features. Long QT2, most likely in our case it was long QT2. Okay, you can go back and see this. See the notching over here. You see the long QT2 notching. So if a notch occurs in the T waves, this is long QT2. Okay, the amplitude will be low amplitude, notch, or bifid, just like in our case. And long QT3 is pretty distant, so it will take a very long time to start, and then with a very prolonged isoelectric ST segment. Okay, so this is different from these two. And then you see a very long isoelectric ST segment, and then T wave takes off, which is not broad based, which is a narrow, and which is more of peak rather than a slope, smooth rounded. Then this is long QT3. Okay, just remember these things. Just remember the picture. Identify. Just remember long QT2 or long QT3. Anything not 2, 3 is long QT1. So if you can't remember QT1, remember QT2 and 3. I think they can be remembered pretty easily. I think this is probably last slide, or there's one more. So I'll give you the history. It's a ischemic cardiomyopathy patient with EF 25% who presented with palpitations. This is ECG, blood pressure was 100 by 70. So what is the diagnosis, and what are the findings, and what would you like to do in this patient? Anybody? It's a bit challenging one, so I have put a tough ones at the end. So, but I think any ECG can come, so you have to prepare for all the ECGs. So he is a case of cardiomyopathy with EF 25%. There is no signs of hemodynamic compromise. Anybody who would like to comment, just give the diagnosis. Okay, so this is a tachycardia. There's no doubt about it. Can you see a P waves before these QRS complexes? Any discrete P waves? You can say this can be a sinus rhythm going on. Look at the heart rate. Look at the rate of this tachycardia. So it's around 160, 170 probably. Okay, so it's not that, it's pretty fast. So any patient who's having ischemic cardiomyopathy with EF 25 and this heart rate, so sinus tachycardia is very unlikely. See why he will be having sinus tachycardia at such a fast rate, 160, 170, with such a bad conduction system. So he's having these broad QRS complexes. So this doesn't look to be a sinus tachycardia. So what else? So obviously you have to rule out VT. Okay, so you have to rule out VT. So anything that favors VT or goes against VT. So what are the criteria? Anybody who can revise the criteria for a VT for me?
It's a Brugada criteria.
Good, good. So can you tell me what will you see?
The step one is the loss of R wave or S wave in the anterior leads.
Okay,
and
so
step two, R to S from R to neither of S will be more than 100, then it is VT. Third is AV dissociation. And then fourth is you have morphological features.
so can you please apply these criteria and then see which criteria is being met or rejected. So good, you have.
I beg your pardon, sir. There was interruption in your sound.
Sorry, I just wanted to tell you that please can you apply these criteria which you have just mentioned so that the others will also know that are the criteria being met or not. Good, you said rightly, but you have to apply these as well. So
first step, loss of wave or S wave, we can see
absence of RS complex in all chest leads. So do you think it's happening over here? We can
the
see an
second.
R.
Yeah.
Okay. Okay. Yes, please continue speaking.
Yeah, second R to nadir of S, we calculate that if it is more than 100, then it is VT. We have one V6, it looks like a good R wave with the S waves. If we can calculate and we see you.
So do you think it's a bizarre intrinsic deflection? We call this intrinsic deflection from like this from here to peak. So do you think it's pretty bizarre or pretty sharp? What do you think?
Pretty bizarre.
Pretty bizarre. Okay.
Yeah.
So
Only
next
V6 I can see like mild deflection down, but more of R wave is there.
Okay. Okay. Next point, please.
The AV dissociation, but I didn't find AV dissociation because P wave is there. Every QRS is preceded by the P wave, and then QRS, P wave, QRS, P wave, QRS. So it's one-to-one conduction. It looks like here from the long lead to C.
So now this is going against VT. The first point, second point was going in the favor of VT. This point was going against VT. Yes.
And that morphological features in the presence of RBB, the left ear will be bigger than the right ear.
So can you see the ears? They're a bit of a.
Yeah. I don't know, sir, because there are two deflections up there. Is this really true?
So good,
I can't.
good, very good approach. You approach the case rightly, so I appreciate for that. But this is when the things get interesting. You see, so all the features they favor, but very rightly, very good of you to pick. You can see, look at over here. They are pretty kind of same morphology with the same timing. There, it is a regular. Okay, so what do you think these waves are? You said it's a P wave. We did something with this patient. Okay, we also thought because this patient VT is definitely based on history is so important to rule out. So with this ischemic cardiomyopathy and this palpitations and bad conduction, so we were very careful on managing this patient. So we gave him some drug. So we gave him amiodarone because he was stable, he was not hemodynamic compromise. And now look what happened to this patient. You see, this happened to the patient. So what's the diagnosis? So it was an atrial flutter.
Flutter. You
see,
with the variable.
Yes, we managed to kind of widen the QRS complexes. Amiodarone stopped the conduction through the node and it revealed the flutter waves. You see, so this patient was having atrial flutter and it was going so fast and conducting pretty well that you cannot appreciate the flutter waves. So those V2 waves which I mentioned you earlier, that were flutter waves. And now because we have slowed the conduction because of amiodarone, we got the diagnosis of flutter. So there were more parameters which were not favoring VTs, except for one that probably I'm not sure about that, but majority were not favoring VT, although he was all the value for that VT. You see, so the thing is always apply the criteria, although they are not 100%, but always try to look for these hidden P waves or flutter waves as well. Okay, so don't give beta blockers. I'll not suggest you to give beta blockers to block the conduction through the node. So we were lucky to have amidron, slowing the conduction and revealing the flutter waves. But definitely, this cannot be picked unless we see the flutter waves very clearly. So this patient was having atrial flutter, and then it was managed accordingly. I hope it's clear. I think probably this is a few slides are left. So this is spot diagnosis. I think up till now you might be able to put the diagnosis for this. We have discussed so many techies. So what's the diagnosis for this? So just, okay, I'll ask you two questions. Is it a complete AV block or is it atrial tachycardia?
It's atrial tachycardia.
Good.
To me, I don't know about.
Yeah, yes, it's in
It's like-
tachycardia. Yes, this patient was around 40 years old and there was no evidence of AV block in sinus ECG. So don't write complete AV block, please. Sometimes you get confused, but look at the atrial rate. Even the sinus rate with the AV block acute will not be so fast. You see, it's very fast P waves. Look at the cycle length of that. So it's around 160, 170, which sinus is firing at 160, 170. It will not be though that fast. So this was an atrial tachycardia with a functional block. And you see, this was conducting better here. It was a very, very long pause. And then again, it improved. And so it was not a complete dissociation. It was a functional block because of so rapid conduction because of atrial tachycardias. So this was an atrial tachycardia. Okay, you can confuse it with a complete AV block, but look at the sinus rate. It cannot be so fast, even with so many sympathetic drive as well. So this is ECG. It's a very again interesting ECG, and this is the last ECG. So this is a tachycardia. So anybody can comment. Okay, it's a very again a very good learning ECG. So anybody who would like to comment on this ECG? So my question is it VT? Anybody who is in favor of VT? Or VT is not likely in this case? My question is it VT or no VT? Because this ECG might come because you have to differentiate SVT with aberrancy from VT. Yes, this is a thing which occurs in exam.
No VT, sir.
No VT.
It looks like SVT.
Sorry?
Now look at lead V2, you will see the deflections there. It looks like a P wave board.
Okay.
V2, sir. Yeah, regularly coming.
So V2, and look at limb lead 2. And look at limb lead 3.
Yes, lead.
It's more obvious over here. You see?
Yeah.
So now you have seen antidromic AVRT. Yes. Yeah. So antidromic AVRT, please remember antidromic AVRT because it will be mostly with the left free wall pathway. Unlikely right free wall pathway, but you should be knowing the antidromic. Antidromic will be more often atypical because it's going through the pathway and not through the node. But with an aberrancy, it will be going through the node. I hope you understand my point. You have understood this concept. So the thing is, in the case of antidromic, what happens is that the QRS morphology will be broad, but it will be atypical. So now you see, does this look to be an atypical right bundle branch block? This is a typical right bundle. You see, good M RSR pattern is being formed. It is more of a typical right bundle. Ignore V1, but look at V2 and V3. They show a very pretty good right bundle, which looks more of a physiological conduction down the right bundle, the left bundle, because right bundle is blocked. So it was 1-to-1 tachycardia. So VT is unlikely. Now the differentials will be SVT and antidromic. So antidromic again is unlikely. So now look what happened. Suddenly this patient went from this to this. This is the same tachycardia, and now look, it went from broad to narrow. So which is out? VT is out, antidromic is out, right? It is impossible that the QRS is narrow with antidromic because it will always be broad. And again, a VT will also be out. So this patient was a case of SVT with aberrancy. Somehow his aberrancy vanished, and we can see a SVT running along. Okay. So this was an SVT, and here it terminated spontaneously, and then there was a bit of pause, and then the sinus took over. You see? So, and this was the P waves over here. Okay, these were the P waves over here, and here you cannot see the P waves. They also went away because probably they went into the QRS. Okay, so we cannot see P waves over here. So they also went away with this. So there are a few tachycardias. I will not go into detail, but VT and antidromic is definitely out. So this was SVT with aberrancy. So just again see the ECG because they will not give you this ECG for sure. So they will give you that ECG, the previous one. Okay. So I'll show you that ECG once again. So just see this ECG and always think of a typical right bundle and look for the P wave. So 1 to 1, the typical right bundle will be most likely SVT with aberrancy.